Hello, my name is Linda Sezek and I'm a nephrologist at Duke and president of the National Kidney Foundation. This is the first video in a series titled 5 Minutes a Day May Keep Dialysis Away. It's a bit of a tongue-in-cheek title, but it's designed to provide in very short videos that can be fit into a very busy day the tools that a primary care physician might need to help diagnose and treat and subsequently combat kidney disease. This first video is really the who cares part. Why do you need to know how to diagnose and treat kidney disease? Why should it be among the things at the top of your priority list? When I sat down to try to answer that question and figure out what evidence I could bring to you to really support the fact that it should be near the top of the priority list, one of the studies that came to mind was one that was published by Rob Foley in Kidney International this year. In this study, Rob found a cohort of patients, U.S. adults, and looked at those factors that were most predictive of their mortality risk. Age, of course, not unexpectedly, was at the top of the list. But second was an estimated glomerular filtration rate of 94 cc's per minute. Not 60, not 30, but 94 cc's per minute. A remarkably high threshold and unexpectedly high threshold to begin to see the risk increase. Number 4 on the list was urine albumin to creatinine ratio. Again, the threshold was far smaller than would be anticipated. Only minor abnormalities in the albumin excretion rate really predicted big changes in mortality risk. Also on the list, although number 11, was an elevated LDL, or elevated cholesterol, thereby justifying all of the effort that we undertake to diagnose and treat hypercholesterolemia. But one thing I would like to point out is the relative differences in the power of these different factors, that a slightly decreased glomerular filtration rate and a slightly higher urinary albumin excretion ratio were significantly higher and more powerful predictors of mortality risk. The next study I'd like to bring to your attention to answer that who cares question is a very sobering conclusion that we've long known in nephrology, and this one is supported by data from Alan Collins' group. Alan looks at a cohort of patients with chronic kidney disease and looks at their outcomes subsequent to their diagnosis. And irrespective of what comorbidities they have and don't have, one can see that patients with chronic kidney disease were more likely to die than they were to progress to dialysis. Now, one of the reasons to measure kidney function, screen for chronic kidney disease, and find chronic kidney disease is to treat chronic kidney disease, to keep these patients out of the dialysis unit. But the fact that this data supports is that it is such a strong cardiovascular risk factor that patients with chronic kidney disease are more likely to die than they are to live long enough to progress to dialysis. I frequently refer to dialysis patients as the lucky survivors. Although dialysis is very difficult on the patient, and I don't think anyone will try to argue differently, they really are the survivors of the group because, as this data suggests, people with chronic kidney disease are far more likely to die than they are to progress to dialysis. So when should you worry? What are the appropriate thresholds? Well, in subsequent videos, we're going to go through in depth how to evaluate serum creatinine, what is the difference between creatinine clearance and glomerular filtration rate, what are the appropriate thresholds, how to evaluate urine albumin excretion and urine protein excretion. I'd like to provide a bit of a preview of that information to say that as you increase your urinary albumin excretion rate or decrease your serum serum glomerular filtration rate, you are getting worse and worse kidney function. And as you look for a threshold above or below which to consider abnormal, there's a certain trade-off between false positives and false negatives, sensitivity and specificity. but a point at which sensitivity and specificity have been optimized, as demonstrated in this study, really underscore the fact that the thresholds are not as low as you would expect with glomerular filtration rate and not as high as you would expect with urinary albumin excretion rate, that even subtle abnormalities in these two parameters really portend a very bad prognosis. So how do you screen? I'll just give you a little bit of a preview, and then the subsequent two videos are going to go into these into even more depth. Serum creatinine, it is what it is. It is easy to interpret, although the advantages and disadvantages of the various formulas that we have to convert creatinine to creatinine clearance and creatinine to glomerular filtration rate should be understood and embraced. That's one way to look for kidney disease. The other way to look for kidney disease is with abnormalities in protein excretion. And the urine dipstick is one of the most simple and easy to use tools that we have available. It's cheap, it's available, and it's easy. That urine dipstick, that pad that gives you a sense for proteinuria, will become your best friend. If you dipstick positive for protein, if a patient dipsticks positive for protein, then you need to quantify that protein excretion using a spot urine protein to creatinine ratio. That dipstick positive gives you the sense that there's a significant amount of proteinuria in that individual's urine. But if that dipstick is negative or only trace for protein, they still could have significant amounts of albumin. We can call this microalbuminuria when present in smaller quantities, macroalbuminuria when present in larger quantities. But a dipstick that's negative for protein still does not rule out albuminuria. And albuminuria is the most frequent abnormality that you will find. Depending on your population, you may find it in up to 20 to 30% of the patients that you treat, while dipstick positive proteinuria you may find in 5% or less. If you get a dipstick that is negative for protein and you suspect that there could be chronic kidney disease, then an albumin to creatinine ratio is the test to check. And we'll get into this in a little more detail with respect to how to order it and how to interpret it. Now, who do you screen? That's a very important question, because in an ideal world with unlimited resources, we would screen everyone. Who are the people that are at highest risk for chronic kidney disease? Well, those would be those folks that have the comorbidities that often convey chronic kidney disease as an end organ complication. Diabetes and hypertension are highest on the list. But chronic use of medications, such as NSAIDs, that may carry with them kidney toxicities, chronic infections like HIV, hepatitis, and autoimmune diseases those patients are also at increased risk. Interestingly, we have recently in nephrology discovered a number of genetic variants that account for a lot of the kidney disease that we see within families, particularly within the African American community. So if you have someone who has a relative on dialysis, particularly an African American, that would be a person that I would think would be at higher risk for kidney disease, and I would have that extra vigilance to keep an eye on them with periodic serum creatinines and urine studies to include a dipstick and potentially an albumin to creatinine ratio. So the next slide that you'll see is a list of some of the topics that we're going to cover in subsequent videos. I hope that you find these little 5-minute presentations of value. I hope that you're able to find a place in your busy day to sink them in and to listen and to take in these facts and then apply them to your clinical practice. Please give us your comments. We're very interested in hearing how this worked for you and how this works for your patients. Thank you so much for your kind attention.